try to prevent you needing so many blood products. You can try to use your own blood. But you see that in a lot of, like, I'd say you'd see that in really bad traumas. So a hemothorax, the lung takes on some type of an injury to the vessels or to the lung itself, and then you get a whole lot of blood in that pleural space. Remember, the blood is not inside the lung necessarily, it's in the pleural space. So if we have someone hemorrhaging this much, of course they're going to have, their color is going to be bad. Of course they are. Of course they're going to be tachycardic. Of course they're going to be hypotensive. Because they're losing blood. They may be in something called hemorrhagic shock, so stay tuned for a shock lecture. So we don't have enough fluid in our body to keep things moving. We could potentially have a lot of blood loss when we put that chest tube in, because think about how is that area going to clot? It's a very vascular area, so we worry about that, but we got to get the blood off in order to inflate the lung, right? There's usually evidence of some kind of thoracic injury. This does not happen spontaneously. I'm not going to say it never does, because there's always one weird case somewhere. Decreased breath sounds, well, of course, because we've got our lungs drowning in blood. It might be dull, though. When you hear it, it might be a very dull sound. Patients usually have anxiety. And what do? We're not giving them a drug. We're going to get a chest tube in again. All roads lead to chest tubes here. So if we have a bunch of blood loss, usually greater than 1,500 mils, you will go and initiate your mass transfusion protocol. Let me preface this, it's probably going to be hospital driven, because now as we have more and more trauma hospitals, and best practices may dictate that we do mass transfusion in other situations. Anybody seen a mass transfusion take place? It's pretty ugly. It's a lot of blood. A lot of blood. Hemothorax, usually blood is white on X-ray, not black. Assessment, you guys know your assessments now. Just feel like it's pretty easy to understand? A little easier than modes on a ventilator? That's probably going to be the hardest thing for you all to grasp out of this unit, are the modes. And I promise we'll do it again and again, Tuesday and Thursday. Okay? And also your assignment that you have. And again, you guys can go ahead and upload it to Moodle. We have too many people out sick with flu, and their kids are out sick with flu. Don't come and give us your cooties on Monday just to turn in your assignment. Just go ahead and upload it to Moodle. That's just fine. And if you want to hand it in, you may also hand it in to, I think, Professor Spencer and Wetmore will be here Monday for a lecture. So all of these things we're going to assess. This is going to give us a lot of good information. Chest tubes. We're going to try to watch a video before we go today on the placement of a chest tube. Sometimes we can do a needle decompression, or we can do a thoracentesis. You may be asked to help with a thoracentesis, where they remove fluid off the lungs. Sometimes, Lewis does talk about this. I will not test you on this either. I'll go study on this slide. We can get these weird pleural effusions when we've got too much lymphatic fluid in the lungs. We usually see this with cancer patients. When all those the fluids start to really shift around in there. Does that make sense to get a light bulb? You're like shaking.
I have a patient right now with lymphoma
that has this?
Double chest tube, yeah.
Yeah. So when we have cancer patients, their lymphatic fluid gets really wacky and collects in weird places. If you have someone that's undiagnosed that shows up with this weird lymphatic fluid in the lung or in the pleural space, you will be asked to assist for thoracentesis, and they will also send that off for cultures to see what kind of fluid is there. For those of you that may be going out to the West Coast, you will see a lot of this kind of thing in something called the desert. I think it's called the desert flu. There's some kind of fungus that lives in the desert sand that's pretty prevalent. And when people inhale that, it lands in their lungs and it mimics, it looks like cancer on an x-ray. And what it actually ends up turning out to be is this fungus, and it turns into some kind of a infection, and then they have to be on antifungals and antibiotics for like 6 weeks, 8 weeks. Usually they get sent home with a PICC line. Pretty prevalent in the western part of the United States. And it usually has this kind of a sign to it. Flail chest is one of my favorite things, because it looks like it's painful, but it's kind of fascinating to me. In order to have a flail chest, remember my son's friend who had to have his whole chest wall reconstructed? He basically had an induced flail chest, fracture of greater than 3 sequential ribs in at least more than 2 locations, which is what makes it flail. You do not have that integrity of the rib cage here. What you have is you have this very messed up, very pliable rib cage, like a baby's, that is on an adult, however. And unfortunately, these patients are in a lot of pain, and there's nothing we can do for them other than intubate them and give them pain medication. So, and you will, you can imagine how uncomfortable these patients are. When they go to inspire, their inspiration, it will actually make those bones cave in, and whenever they expire, they'll pop out. Trauma, lots of trauma. Falls, automobile, like pedestrian accidents where they're run over, horseback riding, where horses roll over on top, bull riding. Yeah, so that's, you can see here, this is another really good, inspiration, caving in, expiration, those ribs are popping out. All we can do is just give them some pain meds and oxygen therapy. This one's a really big one. This happens whether or not you've had trauma, what I mean, like been hit by a car or an accident. This can also happen after surgery, CABG surgery, any kind of heart surgery. We worry about this, which is why we're auscultating all the time. It's a collection of blood in that pericardial sac. Somebody last class had a patient, this over their last clinical, that they did a pericardial centesis because they had cardiac tamponade removed 800 from the sac. It's a lot. I've seen this done on drug addicts. And they come in with some weird heart infection, and their EKG looks very weird and wide. And intensivist comes along and is like, maybe I'll give you the ultrasound, and then they can see the fluid. Sometimes if the patient's stable enough, they can give them some sedative, and they can go in with that giant thoracentesis needle, go through the cardiac window or right underneath the sternum, and pop that sac, basically drain it out, and they'll send that off to a lab. They can also come out with a drain. But Beck's triad is your telltale sign for cardiac tamponade. That's where you have hypotension. Same reason why is because it doesn't have room to pump correctly. You have jugular vein distension, but your stethoscope, for me, is the telltale, like it's muffled. It sounds like this through a stethoscope whenever somebody has cardiac tamponade. I say it probably happens 10 or 15% of the time for random, like for cardiac reasons. And the way that we're going to be able to treat this is through pericardial centesis, which is where we take that needle to the heart. Or we may have to go into the heart, open them up, and do a pericardectomy, which is where we actually go into the sac, vacuum that out, and put it back together. So my heart people, there you go. A little something for you too. That's what it looks like on an x-ray. Pericardial sac is filled with fluid, preventing the heart from pumping correctly. Do you see how all this ties back into, we may need to intubate this person. Is this person in ARDS? Is there something wrong with their heart, or is this an alveoli problem? pain meds, vital signs, hope you don't get an infection. You're gonna die. Remember, this course should be called seizure, coma, death. There's a lot of death here. Haven't seen any comas yet with this or seizures on this particular unit. I'm not gonna test you all specifically on this. You'll get some of this whenever we do AAAs, but just know this exists because patients will come in and they'll have strange symptoms that are very subtle, and then they die. They'll say, I feel like I have indigestion, or I have a stomach ache, or like I got this weird pain right here, and then they're dead. Smokers are at really high risk of AAAs because it weakens their vascular system, right? Diabetics, why? Because being a diabetic is like having rust in your pipes. It weakens the vascular system. Of course, we can have all sorts of trauma that would cause this, but some other things that are coming up, those are the other things that we see when we talk about aortic disruption. Yes?
Is this different from the aortic dissection?
It is in that the aortic dissection is where the layers peel away. This usually has to do with something that's caused it, like a steering wheel or a baseball or being tackled on a football. But what's interesting is that when we're talking about anything aortic, and that's a really great question, is that I always think that if I were an ER nurse, I would be on high alert all the time when somebody comes in with trauma from ear to ear. And B, when I have people that are complaining of that weird belly ache, and they have a history of smoking, or they have weird chest pain, because in my mind, what I'm thinking is, are they having a dissection? Did this 40-year-old, did he fall off the roof and didn't want to tell anybody, and he's really got some kind of aortic disruption here? Because once that aorta is gone, that's it. Like, you can have long-term kidney failure damage if that blood in the aorta is disrupted. So this is one of those things, remember, it's a little bit on the quiet side, it's subtle. If you get a patient and you work an ER job, you get a patient who's been like, okay, everything's okay, and they start to have, gosh, my back is hurting. Like, you shouldn't be like, yeah, of course it's hurting, you just got into a wreck. You should be in the back of your mind thinking that this is a silent killer. We need to make sure that we've gotten checked out okay. And you look here, like possible neurodeficits. If you have a neurodeficit, is the first thing you're gonna think as a brand new baby nurse, or you're gonna be thinking, this could be his aorta. No, you're gonna be thinking he's got a brain bleed. So remember, it's like, here you are in MP4, we've given you all these puzzle pieces, and we haven't given you the picture of what you're putting together, or, we're not giving you the color of the pieces. So these are things for you to think about if you find yourself in the emergency room on your clinicals and someone's had a terrible accident, because you are going to Baptist now, which is trauma 1. You are also going to, you've also got all sorts of ER slots everywhere, and they can bring anybody in at any time. Furthermore, you live in Oklahoma, and who would have thought we would have had tornado days in November? So there's a possibility that you all can be, in a situation where you may end up having to just, you might come across some of these things. And we have had a long history, Professor Wetmore's been here much longer than I have, but our students have had a very good track record of saving people. And what I mean by that is that one of our students will say to their nurse, hey, I don't know if this is right or not, but like, could this be maybe a thoracic aortic disruption? And the nurse goes, wait, what? And they go check it out, and then we get called and we're told that had that student not have mentioned that patient would not have had a positive outcome. My own BATNAP class, one of my friends recognized the beginning of a grand mal seizure and saved somebody from aspirating. She drug him out of the chair and turned him on his side.
Wasn't it mental health clinical?
I don't remember, it was Crystal.
Yeah, I think it was mental health clinical, actually.
I can't remember.
When you're not supposed to use your med-surg stuff.
No, so we've had different stories along the years of people doing that. So Yeah, but think about the dissection, it's coming up, and that's also very, I mean, it's along the same lines. This is from trauma, the other is from smoking and vascular issues. This makes me very nervous because of all the things we just talked about, blunt cardiac injury. The cardiac system is probably very bruised, but then I'm also thinking of all the other things that could go wrong when I see a patient like this. Does my ER department think the same way I do whenever you see these things? Have you ever caught somebody whenever you've assessed your patients, have you found something that the physician has missed? Yeah? You have a good story? Something that you're like, holy crikey. Car accidents are pretty scary. I think when they're bad, they're scary because you're really you can also get these diaphragmatic tears, which is the blunt trauma ends up tearing the diaphragm. That's part of it too. Esophageal disruption, again, trauma that injures that esophagus. Not testing you on any of these. Pulmonary contusion, I do want you to know, because that really affects our respiratory status. If our patients have pulmonary contusions, they do not want to take a deep breath. They will have usually blood in their sputum. You're going to see those poor little opacities in their alveoli because they've been injured, so they've got some fluid in them. The breath sounds are going to be diminished, probably going to have crackles from the fluid. And they probably will develop some kind of hypoxia or hypercapnia. So we're probably going to end up ventilating them if it's bad enough. We've just got to make sure we maintain their oxygen really well, and really do some good breathing exercises with them and mobilize them if we can to prevent them from getting, pulmonary edema and infection and that sort of thing. Pulmonary contusions are very common in car accidents and very common in pedestrian accidents. This is for your lab. It's going to give you where we like to do chest tubes and decompression. Second intercostal space, midclavicular, or fourth, fifth intercostal space, interior axillary. Don't like that, makes me nervous. What do we call that sign? Seatbelt sign. So if I'm the nurse, I'm assessing everything in that area, plus the lap belt that goes down. Is there anything about this picture that you do not like? The chest? Okay, so I have abdomens distended. We've got, you don't like the way that it looks like some kind of trauma happened where it looks like something got pushed up and in. So tell me the things that we would be worried about out of the things that you've seen. What's one of the things you're going to be looking for? What? It's okay. A GI bleed, okay, could be. Could be. A flailed chest, could be. All right, that's good. What else? Breath sounds, okay. What about cardiac tamponade? It looks like you took a. We're going to be looking at all this. Maybe a pneumo. I can't really tell if one side's bigger than the other. I do not like how distended his abdomen is at all. But I mean, maybe he drinks too much beer. I don't know. But, and look over here. This is super discolored. There's a lot of things that we see from here that say this person might not be okay. On the outside, they look like they're just fine. But if they're your patient and they're talking to you, I'm still not saying that they're out of the woods. I'm concerned that they're not out of the woods, that we just started to enter the woods. Okay? There's another seatbelt sign. There are two things on this that I don't like besides the seatbelt sign. I don't know what this is, and I don't know what this is here. So I'm not going to dismiss that he has nothing wrong on that side with his respiratory. Lots of assessment skills here and where we're using our stethoscope and what we're monitoring. A what?
I don't like how his spine looks.
Yeah.
How he's so
like arched back.
yeah,
Yeah,
I don't like it.
it's good.
And though we're not a seat collar. But
Not wearing a seat collar.
beside the point.
Yeah, I mean, you can see now that before you probably had this lecture, you walk in and you see this and you go, I don't know what happened to him, he's got a seatbelt sign. But when you're thinking critically and you're digging deeper, now you're thinking, why is his spine like that? Why is the abdomen distended? Does he have a pneumo up here? What is this mark down here? Has he done some other injury? Did he maybe have does he have a coiled chest? Because I don't know what, this right here, this seems to be a little more caved in than what it should be. I don't know, he's not here and we can't assess him. But you start to think deeper about all the things that could be wrong. Could be.
Well, there'll be signs.
Their oxygenation usually gets worse, and a lot of them come in with carbon monoxide poisoning. So, on this guy, obviously, we gotta secure his airway because he doesn't even have a facelift. But, not to mention the chemicals that they've inhaled. They could be chemical burns from all the junk that's burning. Oil rigs blow up every once in a while. But think about household products that catch on fire, all the nasty stuff that and if we don't have proper working fire alarms, or maybe we have, maybe this person was not able to get out of their house. So, just know that's coming up in your future lectures, but this is also part of your respiratory deals that when we see burn patients, we almost always ventilate them because they have a difficult time reaching any kind of maximum oxygen capacity. Not because of their capillary issues, but it's because they've got all the residue of the fire down into those lungs that have clogged those alveoli, and or they have carbon monoxide poisoning. So so everything's mimicked oxygen, and all of our oxygen receptors. I probably should do this because I haven't done this yet. So your oxygen molecules. Let's do this. This is your red blood cell, and every red blood cell has 4 carnivores for an oxygen molecule. When we know that with the red blood cell, when we get that reading that says, hey, you're at 98%, what that means is that on your red blood cells, that 98% of your carnivores are completely full with oxygen. Okay? Especially on an ABG. It's really probably most accurate on ABG. The SpO2 tells you how many have gotten off. The ABG tells you how many are on here, okay? So what happens is when we have carbon monoxide poisoning, the red blood cell thinks that the carbon monoxide is tall enough to get on these rides. So then that's why we get the weird readings that say that their SpO2 is 98% when it's really full of carbon monoxide. And the way that we have to get rid of that is part of their respiratory treatment is we have to send them down with Dr. Nectow to go do what they call the hyperbaric chamber. They go on a deep dive to try to offload those carbon monoxide molecules and to onboard oxygen. I see some light bulbs, they like that. Respiratory to me is so fascinating. This guy, I hate to say it, this might have been a result of a suicide attempt. Also could have been somebody running with scissors. But the only way we're gonna get an airway here is we're gonna end up having to do a trach. And obviously, the sounds that we're gonna hear from that, we're not gonna be able to get a good airway going this way because he's probably nicked his trachea somehow. It could have been in an accident, like a motor vehicle accident where something was projected, a projectile that almost decapitated him. Just some more for you to just peruse through. I try to make it to where you can use these as your primary source of studying and not have to go through all the dense stuff. This is your thoracentesis. I've helped many a physician do this. Our person comes in, they've got all this fluid in that pleural space. We come in, we tell our patient, all right, we're gonna give you maybe a Xanax or some Ativan. We're gonna set you up on the side of the bed, put your arms over the top of the table. You're gonna give some lidocaine in that spot. I'm gonna probably have blood culture or something like that. They have these giant culture bottles. Physician then does some lidocaine, and then they go in there with that needle and they draw out that fluid, and we send it off to lab. Usually they feel much better right after. And again, I usually see this with cancer patients. There are some nursing diagnoses that may need to, if you need them for your, care plans. I mean, look at how easy these drugs are. These are easy. Know them by class. This is a bronchoscope. If you guys are lucky enough, maybe you'll go on day shift over to Saints and find Dr. Karen Allen and see whether or not if she has to do a bronchoscope, she'll let you watch. This is where they go in and they can see everything in the lungs, and sometimes they'll vacuum the stuff out. Those big old thick loogies, she'll just get in there and grab those. It's a great way for them to actually see the structures of the lungs and to see what they're looking at when there's difficulty. So that's called a bronchoscopy. They can do that at bedside. This is not a real person. This is a chest tube. This is for your skills. Next week. Next week. So get to touch and feel these. I'm gonna try to find this video just to finish the class up here. I want you to see this. This really is how they do chest tube insertions. This is not, I'm not pretending. They go in, they do the lidocaine, they take the scalpel, and then the physician sticks their finger into the pleural space. Isn't that crazy?